All right, let's hear what Rose Apondi is going to say. Rose is a public health specialist with the U.S. Centers for Disease Control and Prevention. She has a master's in public health from Liverpool University and a social work degree from Makerere University. Currently, she serves as the co-chair of HIV Prevention Technical Working Group for PEPFAR, under which CDC is funded. She's point of contact for gender, both for CDC and PEPFAR. She'll be talking about the implications for service delivery and policy for intimate partner violence, stroke GBV, and HIV. Well, yeah, those are the conflicts. What is it? Okay.
Thank you very much, Jesse. And again, good morning. It's afternoon, I think. It's still morning. Okay. I think it's big shoes speaking after Charlotte and Samuel, the conflicting data that we are hearing. Again, about the nomenclature, talking about IPV, GBV, I'll talk a lot more around GBV and present some of the work that we have had. Next slide. The outline, basically, I'll talk about initiatives for gender-based violence, the coordination of current efforts in Uganda. I'll present a few slides taking case studies from PEPFAR work that has been done. And then I'll discuss some considerations for service delivery, for monitoring and evaluation, and some policy implications. Next. In Uganda, the Ministry of Gender, Labour and Social Development again takes charge mainly of the coordination of the response. Like you heard before, Uganda is a country where we have a lot of laws. Laws are not our problem. They are there, but the problem is around implementation. We have the Uganda Gender Policy, 2007. We have a Domestic Violence Act, that is 2010. The Prohibition of Female Genital Mutilation Act. And then there is a Prevention and Punishment of Trafficking in Persons Act. So we have a lot of legal frameworks to support work around gender-based violence. And then there are other sectors that have also taken a lot of interest. Under the Uganda AIDS Commission, we have a national prevention strategy, and in that strategy, it's very clear that gender-based violence is an issue for HIV. And this has specific actions on what programs are expected to do. Then from PEPFAR, where I come from, we have a PEPFAR gender strategy, and in this strategy, gender-based violence is one of the key issues that we need to deal with if we are going to prevent HIV. And there is an increased focus in the Ministry of Health looking at gender and sexual-based and reproductive health issues. So gender-based violence ideally should be dealt with in very many different areas. And we have a lot of very strong non-government organizations that deal with gender-based violence across the board. Next. Back to the Ministry of Gender, Labour and Social Development. They lead the coordination around gender-based violence. We have a gender-based violence reference group that coordinates the many different organizations. And this is a meeting point whereby different actors can meet and discuss issues at different levels. At the district level, we have also committees, and these committees are multi-sectoral. We have different groups from the social development, from health, and other actors. And from the Ministry of Gender, there has been a pilot taking place working with shelters, and this has been, it has been piloted in around 8 districts. And victims, especially in areas of war, we find that these shelters are being piloted much as not so much information in terms of evaluation have been shared. For prevention activities, community dialogues are key. Those are some of the avenues that are being utilized. The SASA model, which has been adopted from Raising Voices, whereby as you all know, SASA is a Swahili word meaning now. We need to deal with gender-based violence now. And it actually utilizes an approach that looks at benefits other than just blaming whoever is a perpetrator. So it has been looked at as bringing the men on, bringing those people on such that we work together on the issue as a team other than pointing fingers. And it has been found to work. And the Ministry of Gender is working with about 30 districts currently so as to try and make sure that gender-based violence is dealt with. The ministry takes on the capacity building leadership, and there is a lot of resources within the Ministry of Gender, Labor and Social Development, and it also takes on lead in the development of policy. Next slide. In relation to PEPFAR Response, currently we are working with HIV programs to identify victims. The earlier discussant was talking about what works and what doesn't work. And when you come to the health world, many people will tell you gender work is not our work. That is somebody else's thing. It should be done with the Ministry of Gender. And many times when you talk gender, anything around gender, everybody thinks you're just yapping about women. But this is not it. I think the realization that it is beyond women has started to dawn, and the different sectors are now beginning to understand that we need to work together if this problem is going to be dealt with. We do have 2 key indicators that monitor gender-based violence, and we do targets and also put budgets specifically to make sure that we work on issues around gender-based violence within our programs. Implementing partners have issues around capacity. Many of the health workers do not know what to do, and this is a big issue. And again, looking in comparison to the other problems, I mean, in Uganda, HIV prevalence is, from the last AIDS indicator survey, is 7.3, and this is a big issue. Compared to the rates that we see in gender-based violence, I think we would have dropped everything else to run and make sure that this is something we are dealing with, because the rates of gender-based violence are very high. I'll present a few slides in a minute to show you how high. In our programs, we do offer post-exposure prophylaxis to rape victims within the policy that is available, and we have tried to map the existing services because we are not able to offer everything as from the health side. It's important to know who has anything outside there around us so as to be able to refer those whom we find, because it doesn't make sense to identify and just leave a victim as is. So it's important for us to partner and find out who else we can work with in order to make sure that there's a response for all that we find. The new programs that we have are now including formative assessments to make sure and identify gender needs, and these ones include making sure gender-based violence is dealt with. And data collection is one of the key initiatives that we would like to have done so as to be able to explain the extent to which gender-based violence is happening and improve our HIV programs. Next. I am going to present some data from a crane survey which was implemented in Kampala. And this was to better understand gender-based violence occurrence among female sex workers in Uganda. We used data from a 2012 crane survey, which survey began in 2008 and is administered to high-risk populations, including female sex workers in Kampala. The crane survey was designed to monitor trends in HIV and in STIs, and to identify and describe high-risk factors. The crane survey is funded by PEPFAR and is a collaborative effort between the Makerere University and the Ministry of Health in Uganda. Our conclusions from this survey include the occurrence of lifetime rape was experienced by 49.4% of those women reporting experience of lifetime rape. And 38% stated that they were raped 3 or more times in the last 6 months. If really we are looking for data and want to think about this as a big problem, what would you be waiting for when you have rates as high as 49 and 38%? That is more than a third of the women we are talking about. We also found that occurrence of client-initiated gender-based violence, this is among sex workers, was extremely high. 82% of female sex workers reported experiencing gender-based violence in the last 6 months, and 52% of these have experienced 3 or more forms of client-initiated gender-based violence in the last 6 months. When we looked further to see what was associated with gender-based violence, we found that frequency of client-initiated requests for no condom use. Again, the data sort of speaks back to what Charlotte was saying earlier. And then the length of time working as a sex worker. We found that when a woman had been a sex worker for longer, it's more likely that she would be experiencing gender-based violence. And then the third one was that for women, we found out that where they were having sex had something to do with whether there would be gender-based violence or not. Next, please. Again, we find the very high rates of gender-based violence, and increasingly, evidence shows that gender-based violence is both a cause and effect for HIV. So I am going against some of the data that you were showing earlier. And violence and fear of violence can prevent testing, care, and treatment. If a woman is going to think about what is going to happen if she comes for a test and is going to go back home and be beaten, then it's most likely she will think about not accessing the services. If I am going to come to a facility, I'm pregnant, coming to have a baby, and the first thing you tell me is I'm going to have a test, and part of the test means I have to go back and disclose. My business here was not HIV. My business was I'm pregnant and I'm coming to have a baby. And you are telling me that I have to be tested. So do I go back home to say that I am the one who has brought HIV? It's difficult to have that discussion. And our programs need to understand that we may be putting people at risk if we are not thinking about what our program means. We may mean well in terms of getting you onto treatment to make sure that your baby is better, but if we are not looking at it into the context of the bigger context, what are the cultural norms? A baby in Africa, in Uganda, belongs to more than just me and the father of the baby. There is a bigger group. What will I tell my mother-in-law? What will I tell other people? Why are you not breastfeeding? All those questions need to be part of our plan as we put programs together. Globally, women who engage in sex work are 13 times more likely to be infected with HIV than other women. And I have the different quotes from where the data is. And stigma surrounding sex work leaves women at risk of experiencing GBV and making it worse. In Uganda, for instance, sex work is illegal. So it's difficult for us to even start talking about policy around 100% condom use. In other places where sex work is legal, it's easy to talk about certain interventions, certain policies. But where even the problem itself, where you're starting, the woman who is more at risk has very many problems. Apart from going to sex work in relation to having no money, then sex work is illegal, then she has problems during the sex work. So where does she turn to? So those are the big questions we need to be thinking about if we want to actually deal with GBV and HIV. In terms of programs, we are using a multi-sectoral approach because we do not do everything. When you show up at the facility, we are talking about how you're going to get to the police. If you say you have been raped, there's a certain time between which we can actually intervene. Now, if you're unable to bring up the evidence, then it means we are going to fail to intervene, and yet sometimes our own policies, our own pathways are a problem in terms of getting the services on time. Would like to make sure that the training manuals for sex workers are actually, there's something that we can use and actually are effective. You will find that at a typical health facility, it may be one midwife and one, the reality is that it may be a nursing aide manning a facility. Is she going to be able to do all the testing, make sure she checks the woman, make sure she does a screening? All those questions we need to think about in terms of programs. Next slide, please. In terms of resources, gender is one of those things that sitting where I come from, everybody will tell you it's cross-cutting. What does cross-cutting mean? It means that you'll not get any money. So if you are going to be doing work with cross-cutting, how are you going to make sure that you actually get resources? How are you going to make sure that people are able to understand that if they don't deal with this problem, then our bigger program is not going to succeed? So resources are a big issue. How we count is a big issue. How we are able to ensure that actors are accountable is a big issue. Capacity building, I mean, there are so many things that this nurse needs to get. She needs to begin thinking about treatment for prevention. Test and treatment, she needs training to do her work, her other work. So they feel like screening for gender-based violence is an addition. You're adding more work, you're bringing more women work onto me, and yet I already have other things to do. Next, I think I'm running out of time. In terms of monitoring and evaluation, we need to make sure that we have indicators that we actually can follow. It's difficult to count certain things. For instance, gender-based violence is not just something you're going to count in one time. It comes from the background of social issues. It means it's qualitative. It means there are many other underlying issues you need to understand. Just having two indicators may not help you to actually be able to tell where and how the problem has come. So in terms of what we do, we need to at least at a bare minimum understand from the data that we have. Before we even go further, are we having sex aggregated data? In that data, are we able to start thinking about how our programs work and where the problem may be? So we could start with where we are now and see where the avenues and opportunities are. And again, I agree with Samuel, we need to do a lot of spatial studies and operations research to understand where our money will be best spent. My last slide is around policy considerations. Again, working with the Ministry of Gender and other government, we need to look at how population-wide programs can be implemented. Where is it where we need to put our money? NGOs can support specific groups that are at very high risk, but they need to be supported by the different actors. We need to utilize the data that we have to inform policy, and if we cannot do that, we are unable to actually get that money, which is cross-cutting. My last slide, I would like to acknowledge the government of Uganda, PEPFAR, implementing partners, and 2 colleagues from headquarters. Thank you for listening.